Thank you everyone for joining us today. I really want to take the time to thank you for taking your time out of your busy schedules to hear from us. My name is Abby Vogler. I'm part of Genoa Healthcare's Pharmacy Solutions team and very excited to be back with you this month to cover long-acting injectable antipsychotics in practice today. Before we jump into the content, I would like to cover some of the logistical items. It looks like a question came in about being automatically muted. Yes, you should be. Also, this webinar is being recorded and it will be made available to you following today's presentation. You can rewatch it or share the link with your colleagues as you'd like. We do expect that the presentation will last about 45 minutes today, and that will include the question and answer session. So please do submit any questions that you have along the way in the Q&A section. You'll find the icon at the bottom of your screen. We will save all of those questions for the end of the presentation. If we don't get to your question today, we will follow up with you individually after the webinar. But we want to make sure to give you enough time to get to your next meeting or appointment. So again, expect about 45 minutes. We will also be asking for your participation in audience polling questions today. The question should pop up on your screen in a second window where you can select your response and hit submit. I do want to just give a quick heads up into the last poll question that you'll see at the end of the presentation, and that's really to give you a chance to think through your responses. That question will be about what topics you would like to see Genoa cover in 2022 for these clinical webinars. It's important that we provide you relevant and effective and important information, so we're really looking forward to those responses and wanted to give you some time to think ahead. So with that, let's go ahead and get started with today's webinar. Again, my name is Abby Vogler. I'm a pharmacist by background. I've been with Genoa Healthcare for about 11 years now. Really excited to have the opportunity to be back with you all again today to share more about long-acting injectables in practice and how Genoa Healthcare can support you and your patients with access to these types of medications. I have with me two of my dear colleagues. Michelle will be answering any questions related to our COVID-19 updates. She is our subject matter expert, and so she will be covering that topic for us today. And of course, our favorite moderator, Lindsay, joins us again, and she will be helping us with the audience polling questions, as well as any of the chat that comes through or the questions that you submit throughout the presentation. So I want to thank you both, Michelle and Lindsay, for your time and your support today. With that, a quick agenda overview. Today, we will mainly focus on long-acting injectables and specifically around antipsychotics available in this dosage form. And of course, like we have been lately, end our time with an update on the COVID-19 and as it relates to any of the vaccination updates or antivirals. I'll pass it over to Michelle to provide the latest and greatest information there. Now, many of you are probably familiar with the term LAI, or long-acting injectable, and there are other similar terms such as LAA, or long-acting antipsychotic, or LAM, long-acting medication. I will mainly be using the term LAI throughout the presentation today. You're probably aware, but just as a reminder, LAIs are medications that are administered by a healthcare provider, often in the deltoid or gluteal muscle, and they are unique in that their therapeutic effect lasts over an extended period of time. And this can certainly be advantageous for certain conditions or patient populations. And while there are a variety of disease states that LAIs are available for, today we're going to focus on those in behavioral health, specifically antipsychotics and schizophrenia. With that, I'm going to hand it over to Lindsay to do our first audience poll question. Lindsay?
Thank you, Abby. Everyone, we're interested in your experience. Are your patients aware of LAIs as treatment options? I'll give everyone a minute to answer yes or no. Okay, thank you. We can close the poll. And there is an overwhelming yes response. 91% of our participants state that their patients are aware of LAIs as a treatment option. Abby, I'll hand it back to you.
Great, thank you, Lindsay. It's always good to get a baseline of where people are at and how patients are perceiving this as an option for us. I want to talk a lot about LAIs in the role in schizophrenia today, so let's jump into that and looking at the schizophrenia treatment journey. Now, many of you are aware that schizophrenia is a chronic, progressive, and debilitating mental disorder that affects how one can think, feel, or act. Patients can experience a wide variety of symptoms, which may include delusions, hallucinations, agitation, disorganized speech, or impaired cognition, for example. It is estimated that about 1% of the world's population will develop schizophrenia in their lifetime, and around 3.5 million people in the US are currently diagnosed with the condition. So as we look at the treatment journey for schizophrenia, I know every patient's individual experience is different, and this graphic is meant to represent an average presentation. Although schizophrenia can occur at any age, the average age of onset tends to be in the late teens to the early 20s for men and the late 20s to early 30s for women. The long-term course of schizophrenia is marked by periods of remission, either partial or full, and broken up by relapses that often occur in the context or as psychiatric emergencies that often do require hospitalization. In fact, approximately 80% of patients experience multiple relapses over the first 5 years of treatment, and with each relapse, it can carry risks, such as a loss or worsening of function. Perhaps a patient may become refractory to treatment, or changes in the brain morphology can occur. Now, from a treatment perspective, you can see that it often takes a couple of years from that first presentation or onset of symptoms for a patient to receive that definitive diagnosis. From there, oral antipsychotics are started, usually to assess for tolerability and effectiveness and response to the drug. On average, patients are actually treated with 4 different oral antipsychotic medications before an LAI is considered or initiated. So as you can see, it can often take years for a patient to start on that LAI. In this case, an average age of onset of 22 to 38 to begin the LAI. And this can be due to several reasons, such as a patient may be hesitant, the prescriber may be hesitant, or might assume that the patient isn't interested in an injectable form. Maybe the patient is unaware. Maybe they don't know that this type of treatment option exists. There could be concerns about costs, as these are expensive medications, or stigmas around the LAIs as a viable option can exist. For example, a patient may think their provider doesn't trust them to take a medication every day, so they're forcing them to take an injectable form. Now, these are all really important things to consider as we think about the recommendations, especially as recently experts are suggesting that LAIs should be considered earlier on in the treatment journey for schizophrenia. So let's take a look at how that conversation is changing. Now, many of you are probably aware of the APA guidelines as it relates to the recommendation of an LAI or oral medications, and current guidelines from the APA do suggest LAIs for specific patient populations, for example, where personal preference or non-adherence may be present. Now, clinical guidance from the American Association of Community Psychiatrists, evidence from the National Institute for Mental Health and other research organizations, and the National Council for Mental Well-Being encourages healthcare professionals to use LAIs earlier rather than after multiple treatment failures, relapses, or hospitalizations. In fact, in an article that was published in JAMA Psychiatry from around July 2020, a randomized trial examined the time to first hospitalization in early phase schizophrenia. There were multiple mental health centers across the US that were randomized to either encourage treatment with once monthly aripiprazole or treatment as usual. The primary outcome of the study was time to first psychiatric hospitalizations in patients who had been initially hospitalized, had a diagnosis of schizophrenia, and had less than 5 years of lifetime antipsychotic use. The LAI group produced a significant 44% reduction in the incidence rate of first hospitalization, and the number needed to treat to prevent one additional hospitalization was 7 participants treated with an LAI compared to with usual care. Other randomized controlled trials have also reported the superiority of LAIs over oral antipsychotics in first episode or early phase schizophrenia. A study by Schreiner et al. Saw a substantially longer time to relapse in their LAI group, and Subotnick et al. Reported a significantly lower relapse rate in patients on long-acting risperidone versus oral. So as we think about this conversation change and how to discuss LAIs with your patients, the National Council has provided the following recommendations. First, begin the conversation early on. Provide a clear and optimistic message about this as a treatment option for the patient. Ensure that the patient understands that it does begin with a trial of the oral medication, and this is to ensure tolerability and response, and also to avoid any severe adverse reactions that may occur with the medication. Also, it may be important, depending on the drug of choice that's used for the patient, to continue prescribing and using that same oral antipsychotic for a specific period of time as the patient transitions to the injectable form. Also, consider the patient's need for any anti-extrapyramidal syndrome or EPS medications. Patients actually may already be taking these medications to help with EPS or some of the movement disorders, so monitor each patient to determine if those medications should be continued, tapered, or whether a dose adjustment is needed. Make sure that the patient knows that they will have easy or convenient access to receiving their injection. Providers can improve access to LAIs by administering them themselves, using the nursing staff they've trained to administer those LAIs, or partnering with a pharmacy like Genoa to administer the LAIs on site. And if there is a suboptimal response to the medication, there are other options to consider, like checking plasma levels when appropriate, depending on the drug, or perhaps a PGX or pharmacogenomics test might offer some metabolism insights, or adjust the dose as needed per the guidelines or the package insert. Now, there are several considerations for an LAI. Of course, there are risks to each medication, hesitancy, and certainly stigmas associated with these medications. But thinking through those considerations and the benefits will help a prescriber and a patient determine when an LAI is most appropriate for that individual. So, for example, personal preference is something we've discussed. A patient may just prefer this type of dosage form over having to take a medication every day. Sometimes it can be assumed that they wouldn't want to have an injection, but asking the patient how they feel about this option is an important place to start. Patients who transition from an oral medication to an LAI may also benefit from issues where non-adherence might be present. They will have a reduced pill burden, maybe a simpler medication regimen, and it takes away that need to make a decision every day, sometimes multiple times a day, as to whether or not they're actually going to take the medication. The other thing about this improvement in adherence is that it can actually be verified by the healthcare provider, because they know that if a patient is showing up for their injection appointments on a regular basis, that blood levels with the drug are going to be more consistent as well. Perhaps a patient's living situation might be a reason why they're suitable for an LAI. For example, there are patients who are homeless that may prefer to actually go to the clinic on a regular basis for an injection rather than try to keep track of a bottle of pills on a daily basis. Now, transportation issues should also be considered. Asking the patient upfront if they feel as though getting to their scheduled injection appointment due to transportation would be an issue. There are certainly several ways to overcome this barrier, but knowing that it exists is critical. Of course, cost and insurance coverage are also important topics. These are medications that are expensive and can often deter a patient from thinking this is a viable option. Helping the patient navigate access to the medication, including whether or not it's covered by their pharmacy benefit or their medical benefit, all of these things can help the patient understand their access. And of course, using your general pharmacist to help navigate some of those resources, such as a patient assistance program, is certainly an option as well. It is common for patients with severe mental illness to also have a co-occurring substance use disorder. A long-acting injectable antipsychotic that does ensure consistent blood levels can also help a provider rule out any reason for relapse. Additionally, it can help improve both adherence to not only the antipsychotic medication, but any treatment that might be in place for SUD as well. Now, we just discussed some evidence for LAIs in reducing relapses or hospitalizations related to schizophrenia. Ultimately, this can help the patient stay at goal and manage symptoms of his or her condition. For patients who are frequently visiting the ER or the hospital, this LAI treatment option may be beneficial to ensure that those therapeutic levels are being reached, but it can also rule out reasons for relapses. And when those patients are in the ER or the hospital, starting that conversation about an LAI treatment option is a good place. Patients may have tried these medications in the past, so for those patients that have had historical or positive responses to an LAI, it might be something to consider when restarting is necessary. And lastly, it's really important to remember that some patients may have experienced trauma or may have negative memories associated with injections, oftentimes when it's involuntary. Reminding the patient that this is a voluntary injection, like getting your flu shot, and what to expect as part of the injection may help alleviate any concerns. So let's take a look at a few of the different antipsychotic LAIs available on the market. I always like to look at this from a historical perspective, so wanted to share with you a timeline of when these medications became available. So again, as we look at the LAI antipsychotics, in their basic form, these are drug formulations that are intended for prolonged or sustained drug release over a period of time, ranging from a few days to months. They've actually been available since about the 70s when fluphenazine, a first-generation antipsychotic, was chemically linked to an oil-based solution. At that time, fluphenazine enanthate was the original formulation that was used as a medication depot. So essentially, by injecting that oily solution into deep muscle, a depot or a pool of medication is formed and then subsequently broken down via the inflammatory tissue response. During this process, that antipsychotic is then slowly released into the systemic circulation. Because of the physical nature of these oil-based preparations, that term depot was used to describe these long-acting formulations and to distinguish them from the short-acting IM formulations of the same agent. So as you can see, we have the first generations that became available, fluphenazine enanthate, and then decanoate formulations. And essentially the decanoate formulation is just the superior formulation, which is why it exists today still. And you can see on the second generation, more and more of these medications have become available. Some have just recently been approved, and also we have some currently under the FDA drug approval process right now. Despite more options available, as well as the evidence that does suggest LAIs have clinical benefits over oral antipsychotics in patients with schizophrenia, schizoaffective disorder, or bipolar disorder, they are still thought to be underutilized. In fact, it is estimated that 12 to 28% of eligible patients in the US receive them today. So while I will share following this webinar a few different clinical pearls specific to each of these medications, I thought the next thing that we should do should cover some of the more general clinical pearls or clinical considerations regarding the long-acting antipsychotics available. So keep an eye out for that one pager that we'll send out after. But for now, let's talk about some of the general topics. First, storage is important. Some of the injectable medications require storage at room temperature, while others, like Risperidone Consta, Perseris, and Vivitrol, require refrigeration. And it's important to remember this because as patients have their appointments scheduled, we need to make sure that there's time for these medications to get to room temperature before the patient receives their injection. From an administration standpoint, most of the long-acting antipsychotics are delivered as IM injections, either in the deltoid or gluteal muscle. The goal is to deliver the injection in the deltoid muscle, specifically for patient comfort, but sometimes that volume of the injection or patient-specific factors requires the injection to be delivered in the ventral dorsal or dorsal gluteal muscle. Additionally, some medications like Perseris actually require a sub-Q injection. Of note, I think it's important to share that a medication like Perseris that is sub-Q, that is actually common for a pocket to form underneath the skin where the injection occurred because it's a depot delivery system. And this can be especially important for patients where paranoia is present, for example. A patient may feel like something is crawling underneath their skin. So letting them know that this pocket is normal, it's common, it's not dangerous, but it's expected is a really important counseling point. Again, it's also really important to remember that patients do have negative memories or experiences associated with injections. So calming any of those fears ahead of time and giving them those expectations will help avoid any of those unwanted side effects. Also, transitioning a patient from an oral medication to its long-acting injectable form, making sure the patient again knows that the appropriate treatment plan for the transition. We've talked a little bit about that and that it can vary by drug. For example, Abilify Maintena requires a 2-week overlap with oral aripiprazole, and Risperidone Consta requires 3 weeks overlap with oral risperidone. One treatment option for starting on Aristada is that on the start date, the patient must have a one-time single 30 milligram oral dose of Abilify plus the Aristada initio injection and the Aristada monthly injection all on the same day. So these are things that could be overwhelming to the patient, but setting the expectations ahead of time, letting them know what to expect can help and go a long way. Side effects can also present with each of the long-acting injectable antipsychotics. Typically, they do have a similar safety or side effect profile compared to their oral equivalent medication. However, it is important to educate and monitor for side effects, especially in patients that are taking multiple medications for other chronic conditions. Some of these side effects or drug interactions may be seen over time, but some can cause serious reactions immediately following the injection. So for example, with Zyprexa Relprev, it's actually part of a REMS program because it can cause post-injection delirium sedation syndrome. And this injection actually requires monitoring the patient for 3 hours following each injection in a registered facility. So again, as we transition from more general considerations, I thought it would be important to highlight a couple of the either brandly new available medications or those that might be approved in the near future. We talked about Invega Half-Year at the last webinar. This is a medication that is Paladone Palmitate as a 6-month injection or twice yearly dosage. And this is the first and only long-acting injectable antipsychotic indicated for the treatment of schizophrenia in adults that is given with a twice-a-year dosing regimen. The safety profile for Half-Year is consistent with those of Invega Sustenna and Trinza, with no new safety signals emerging. And again, it does require oral treatment first to assess tolerability, and then the patient must be adequately treated with Invega Sustenna for at least 4 months, or Invega Trinza for at least 1 3-month cycle. It also does carry that same black box warning for the class, which is increased mortality in elderly patients with dementia-related psychosis. It was just approved in September of this year, and we are seeing that it can be covered either under the pharmacy benefit or the medical benefit, depending on the payer. Genoa Healthcare can actually help support some of the billing through a patient's medical benefit. So if there are questions about certain scenarios or cases, please do reach out to your DOO or site manager for more information about that medical billing support. There is also a medication where Teva and Medincell have partnered to create a new delivery system for an agent currently known as TV46000, which is a long-acting risperidone as a sub-Q injection. A couple of unique factors as it relates to this agent is that it can be stored up to 90 days unrefrigerated and is an every 2-month injection rather than every 2 weeks, which is Risperidone Consta. The new drug application acceptance by the FDA was a big milestone for Teva, and they do anticipate approval next year. Similarly, there's another drug, Rykindo, from Loi Life Sciences that's currently being investigated for the approval in the US. It's another long-acting formulation of risperidone microspheres that is injected IM every 2 weeks. Unlike its reference product, however, there is no need for that oral administration or supplementation following the first injection of Rykindo, and steady state blood levels are thought to be reached much faster. So keep an eye out for that one as well. Now, we've talked a lot about the role of LAIs in schizophrenia and some of the options that are available in the market. What I thought I'd do next is talk a little bit more about how Genoa Healthcare can help you and your clinic with the medications in practice today. So as we think about some of the LAI applications, of course, we've talked about the several options that are available for schizophrenia and bipolar disorder, but several other conditions may be treated with these types of slower release medications. For example, Vivitrol is a long-acting injectable form of naltrexone that's used to treat OUD and alcohol dependence. This is a medication that's unique in that it is given every 4 weeks as a gluteal injection and also requires an opioid-free period of 7 to 10 days prior to the injection. Sublocade is also available as a once-monthly LAI for opioid use disorder. It's a sub-Q injection of extended-release buprenorphine, and we are currently supporting this program and the access to Sublocade across several sites in the country. Cabenuva is also an LAI treatment, this one for HIV, and it consists of 2 once-monthly gluteal injections of cabotegravir and rilpivirine that's actually given as 2 different injections at 2 different sites at the same visit. Now, Genoa Healthcare is able to support access to any of these medications, so if there are any specific questions, certainly do let us know. Now, of course, from a dispensing perspective, Genoa Healthcare can and does dispense these medications today. It's certainly a core part of the services that we provide. However, I thought it'd be important to talk through a few other areas in which Genoa Healthcare can be of service for you. So first, administration. Genoa Healthcare can certainly help administer these LAIs on site for your patients. Now, I'm going to speak generally here about administration because it does depend on state regulations. So if there are specific questions, your DOO or site manager can speak specifically about your state or clinic. But we are administering LAIs across several states today and certainly want to be of support for you. Perhaps you have us as your primary administrator, or you already have nursing staff that are doing this today. Think of Genoa if you need backup or if we need to fill in as needed. Sometimes we have clinic staff where that administrator is on PTO or they're out on leave. Perhaps you might be experiencing staffing shortages. Let us know where we can fill in as you need it. We certainly are always looking to expand these services. We can also help guide in terms of prior authorization. Sometimes it's just understanding those barriers and what are requirements that are needed to be in place before the patient can have this type of medication access. So make sure that you talk to your pharmacy site manager if the prior authorization becomes a barrier for the patient. Patient education is something that we love to do. We want to be a resource for you, your clinic staff, and your patients to answer any questions or concerns regarding these LAI medications. Our pharmacists love spending the time with each patient, and it also helps us to build those trusting relationships that can really make an impact on the patient's care plan. So use us, and also we can help deliver some of that same consistent messaging that you have for your clinic around these types of medications. This education goes a little bit further too, I would say, with dose management. Because we've already talked about how each LAI does have different considerations around the transition from oral to the injectable, but also for missed doses. Some patients may need to miss appointment. Maybe they want to come in early for an injection, or maybe they want to come in later. And we can help you through each individual scenario to understand what to do in terms of dose adjustment for the injection, as well as if any oral supplementation is warranted. A couple other services I just wanted to highlight really quickly was drug screening. We can actually support this in terms of the urine drug screens that might be needed for something like Vivitrol, where we need to ensure that a patient has an opioid-free period. So that is something that we can certainly look into. Just to call out, it does take some lead time to plan out operationally because a CLIA waiver does need to be in place before that type of service can be delivered. Also, we do have a reporting capability, MedAnalyzer, that allows us to run reports that you can help or take a look at to identify potentially good candidates for LAI medication options. So keep these in mind and certainly reach out to your DOO or your site manager for any specific questions. I think I'll wrap up this section here today just to give you guys a real life example of one of the success stories that we had with a patient who transitioned to an LAI medication and how it's impacted their life. I'm sure you have these stories, and we have several of these stories across the country, multiple things to pull through, but I thought I'd actually highlight this one that occurred in Kent, Washington, where we had a consumer, Billy, with schizophrenia, who came from a neighborhood where he had trusted no one, not even his family members. Billy also struggled with being compliant and taking consistent doses of his oral antipsychotic, and his provider had suggested an LAI on several accounts to help increase his adherence. But Billy always refused this option because he didn't know what the doctor wanted to inject into him. He was scared. So the only person that he reached out to that he really wanted to access was somebody that he trusted, which was our pharmacist, Andrew. He asked Andrew what he thought about the shot and what would you do if you were in my shoes. Andrew agreed that this was a hopeful option for him. He was able to talk through the benefits as well as address Billy's apprehension. So Billy did finally agree to try the LAI, but only if Andrew would administer it. So Andrew did agree, and the consumer has said it has since changed his whole life. Billy stated that before the LAI, he felt like he was outside of himself. He was angry, he had fits, and his behavior had broken down several relationships in his life. After the LAI, he is calm, focused, and said it has brought his mind peace. Billy actually came into the pharmacy to tell this story, and as he was talking, he was trembling and tearful, which certainly, as you can imagine, cascaded down to everyone in the pharmacy. It was just one beautiful reminder of the impact that we have and why we do the work we do to keep our consumers healthy. So thank you guys so much for your time today. Thank you for letting me share that story. With that, we'll wrap up this section with one final polling question related to LAIs, and then we'll hand it over to Michelle to provide a brief update on COVID-19. All right, Lindsay, take it away.
Thank you, Abby. Our question is, would you start patients on LAIs earlier in their treatment journey? Or if you're not a prescriber working with patients, is it something that you would talk to your patients about and encourage them to have that discussion with their prescriber? I will give everybody a minute. Okay, we can close the poll. Very similar to our first question, we have 92% who responded yes. Thank you. Michelle, I'll hand it over to you.
Thank you, Lindsay. All right, so let's finish up with a quick overview of the most recent information related to COVID-19. Updated guidance is being released on what feels like a weekly, if not daily basis. So it's important to keep up with the latest and greatest information available. So just a few quick updates that many of you may already know, but J&J, Pfizer, and Moderna have all approved boosters for adults 18 years of age and older. Co-administration with other vaccines such as flu is acceptable, and boosters are interchangeable, meaning it is okay to mix and match with COVID-19 vaccine booster doses. Preliminary data suggests giving a different COVID vaccine brand as a booster dose results in similar or higher antibody levels compared to boosting with the same vaccine with similar side effects. And lastly, immunocompromised patients are still eligible for a third dose. I know many of you with young kids in school and sports were eagerly awaiting the announcement by the CDC on Tuesday, November 2nd, that gave the green light for COVID vaccine providers to begin administration of Pfizer Pediatric COVID vaccine. Early evidence in about 2,300 kids age 5 to 11 suggests this vaccine has about 90% efficacy at preventing symptomatic COVID-19 versus placebo, with similar side effects as those seen in adults. It is a 2-dose series given 3 weeks apart, which is the same as adults as well. For now, additional doses or boosters are not recommended for kids in this age group. It is recommended to tell parents of kids who are close to turning 12 not to wait for the higher dose, but to get vaccinated now. Parents may hear that about 40% of kids have had COVID and therefore may have some natural immunity. But evidence still suggests that vaccinations protects from reinfection 5 times better than prior COVID-19 infection. So even though most kids who get COVID-19 have mild illness, vaccines are still very strongly recommended. So the Omicron variant has been a hot topic lately. On November 25th, scientists in South Africa identified a new COVID-19 variant, which has been named the Omicron variant. It displays more than 30 genetic mutations to the spike protein that the coronavirus uses to attach to human cells. So far, this variant has been detected in at least 20 countries around the globe, including the United States. While news of the variant sparked swift action by several countries to limit travel, public health experts in general have expressed caution in drawing conclusions. Much remains unknown about Omicron, including whether it is capable of causing more severe illness and how well existing treatments for COVID-19 will work. What is known is that the Omicron variant will likely spread more easily than the original strain of the virus, but how easily it spreads compared to Delta still remains unknown. The number of genetic mutations on the spike protein of the Omicron variant have raised concerns about the potential for it to somewhat evade antibodies produced by either vaccination or previous infection. There is also concern of reduced efficacy of monoclonal antibody treatments. It will take time for the scientific community to fully understand whether these potential concerns are valid. For example, earlier variants such as Beta and Mu developed the ability to partially evade the body's immune response. However, they ultimately never became a serious threat because they proved poor at spreading to others. Vaccines are expected to provide at least some protection against Omicron because they stimulate additional immune cells beyond antibodies to attack virus-infected cells. Mutations to the coronavirus spike protein should not weaken the broad immune response that is thought to prevent serious illness and death. All three manufacturers of vaccines approved in the United States have indicated that they are studying the effects of the Omicron variant on vaccine effectiveness. They have also expressed confidence that if a decrease in effectiveness is detected, they will modify their vaccine formulation to improve performance against the variant. In a statement on November 26th, the CDC pledged to vigilantly monitor for Omicron activity within the United States. Until more information is known regarding its ability to cause severe illness, individuals should continue to use proven mitigation strategies, including getting vaccinated, receiving a booster dose if eligible, wearing a mask, washing hands frequently, and physically distancing from others. So we have talked about vaccines as a preventative measure. Now let's talk about potential treatment options with the new oral antivirals that are emerging. Molnupiravir, made by Merck, was approved by the FDA Advisory Committee on November 30th. This is a nucleoside analog which disrupts viral replication by creating errors in the viral genome. The course of therapy is 4 200 milligram capsules every 12 hours for 5 days. It is indicated for individuals with mild to moderate COVID-19 at high risk for severe disease. It must be started within 5 days of symptom onset following a positive COVID-19 test. Efficacy statistics show that it reduces risk of death and hospitalization by 30% and is generally well tolerated. Its use in pregnancy, however, is not advised given its potential for birth defects. In the pipeline is Paxlovid plus low-dose rotenavir. This is an oral protease inhibitor that blocks the activity of enzymes required for viral replication. Interim analysis shows that it reduced the risk of hospitalization or death by 89% compared to placebo. The phase 3 study was actually paused given positive results to pursue emergency use authorization. So as you can see, at Genoa, we are committed to staying up to date on the ever-changing healthcare landscape that impacts our consumers. It is important to us that we are not only a knowledgeable resource for you and your teams, but that we are a part of the solution that improves the health of those we jointly serve. Our pharmacies are providing COVID immunizations and boosters. To date, we have administered over 150,000 COVID vaccinations and are prepared to tackle COVID well into 2022. If you have any questions about if Genoa can provide vaccinations for you, please reach out to your site manager or your director of operations. COVID vaccine related questions can also be directed to vaccine@genoahealthcare.com. So with that, I will turn it back over to you, Lindsay, for our final poll question.
Thank you, Michelle. And our final poll question is, what topics would you like Genoa to cover in 2022? You can use the chat on the side to include that. We want to make sure that the topics we're covering next year meet all of your needs. So feel free to continue to answer that as we finish up our time here. And Abby, I will turn it back to you to wrap us up today.
All right, Lindsay. I'm going to transition, even though we've got the poll question kind of open-ended here as we wrap up. I do want to just thank everybody for your time today. We'll just pause for a few questions as we're looking at this slide. However, I just want to make a call out related to the artwork that I wanted to share. This is actually from 2 of our patients that submitted their pieces to the Genoa Art Contest and thought it was timely for this time of year. So thought it would be perfect to share. With that, Lindsay, any questions you want to talk through before we wrap it up?
Yes, Abby, there have been a few questions that have come in. I would love for you to speak a little bit to the audience about how to discuss LAIs with patients, especially if you're not a prescriber. Do you have any recommendations about what that conversation could include and how our pharmacists address it?
Yeah, absolutely. And I think there's a lot of different tools that we can use. So I could probably talk about this for a while, but I'll try to keep it brief and touch on some of the high points. Again, as one of the resources, the National Council for Wellbeing, there are some awesome tools out there that we can certainly try and make available to you if there are any specific questions or tools you're looking for. But just that relationship with the patient is so critical. That's why our pharmacists love caring for these patients on an ongoing basis. Making sure that the patient is aware, one, that this is a treatment option, that it's an optimistic treatment plan for the patient, and addressing any of their ambivalence or any of their any questions, apprehension that they may have. Things like motivational interviewing can help. Understanding the patient's experience specifically related to medications, but also things like trauma in the past that may deter them from this type of treatment option. So really just taking the time to ask those questions and using some of those tools like motivational interviewing can help. Again, having that relationship on an ongoing basis too is something that would help so that they feel safe in bringing those questions up. So again, lots of things that we can provide in terms of specific tools. So if there's anything specific that you would like to dig into following this, certainly let us know. But these are some high-level tips for you.
Thank you, Abby. There are a handful of questions also related to the experience for individuals using Genoa for their administration. Could you talk me through scheduling of appointments and then what the communication expectations would be back to the care team?
Absolutely. So I will speak generally here as well. I think as you probably can guess, each clinic may have different operational models that we want to support. So I think one of the great things about Genoa is that because we have such a strong partnership with our clinics, we can really adjust as needed, but we want to make it as simple for you, your clinic staff, as well as the patient in this experience. So it can be as simple as having the patient call or stop by the pharmacy, and then we coordinate directly with them to schedule the appointment, but also ensuring that we're communicating back with the care team, whether it's through the EHR and having access and being able to communicate directly with providers there, or ensuring that we stop down and provide the right and appropriate documentation. Sometimes state regulations do also dictate a little bit of what must be done, so we want to make sure that we're meeting those guidelines as well. But I think that the key takeaway here is that we want to make it simple for you and the patient and want to fit within your model. So if there are specific things that we can do in order to help fit into your process, we would love to learn more about that. Hopefully that helps kind of give an intro into how that it can be done, but it can be as easy as just starting with stopping at the pharmacy and asking for more information.
Thank you, Abby. And I think the last question, if we didn't get to your question, we will answer offline. But Abby, the last question is, do patients need to fill all of their medications at Genoa in order to receive an LAI or an LAI administration with Genoa?
The short answer is no. We do not need to have a patient fill all of their medications at our pharmacy in order to use Genoa for that LAI access. As a pharmacist, I would recommend, it's always good for the pharmacist to see the full exposure of the patient's entire medication list, but no, they do not need to. We do recommend that the pharmacist does dispense that LAI if they're going to, one, administer it or provide it to the clinic staff for administration, so we can ensure the appropriate storage and that it's not tampered with prior to the injection. But otherwise, to answer your question, no, that's not a requirement, but certainly something that's beneficial for us to have access to those medications. So hopefully that helps as well. Any other questions, Lindsay? It sounds like that might have been the last one.
That was it, yes.
All right. Well, then I think hopefully we made it just on time. We'll give you guys a bit of time back so you can head to your next meeting or appointment. Thank you again for joining us today. It was wonderful to have you here virtually with us. Again, we appreciate your participation today. Certainly love your feedback as well as your partnership. As a group, we want to be a resource to you, and we look forward to continuing these discussions and presentations. We wish you all a very safe, happy, and healthy holiday, and we will talk to you in the new year. Thanks, everyone. Have a great day. Bye-bye.